Thank you for participating in the 2021 Virtual HPV Summit for Louisiana. This presentation features Dr. Heather Brandt talking about preventing HPV cancers in rural communities. This educational series is made possible through funding from the American Academy of Pediatrics and is brought to you by the following partners: the American Cancer Society, the Bureau of Family Health School-Based Health Centers, the Louisiana AAP, the Louisiana Office of Public Health Immunization Program, Louisiana Primary Care Association, Louisiana Shots for Tots Coalition, Louisiana Vaccine Alliance, Louisiana Primary Care Association, the LSU Health Sciences Center Dental Program, and Southeast Louisiana Area Health Education Center. The Louisiana AAP is accredited by the Louisiana State Medical Society to provide continuing medical education for physicians. The Louisiana AAP designates this enduring material for a maximum of 0.75 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in this activity. For nurses, the 2021 HPV Summit has been approved for a total of 1.75 contact hours of nursing continuing education by Workplace Nurses LLC. Workplace Nurses LLC is approved as a provider of nursing continuing education by the California Board of Registered Nursing, CEP number 13654. To claim credit, nurses must view all 4 sessions in the series. No partial credit will be given. This presentation is being given by Dr. Heather Brandt. Dr. Brandt is the director of the HPV Cancer Prevention Program at St. Jude's Children's Research Hospital and co-associate director for outreach in the St. Jude Comprehensive Cancer Center. She also serves as a full member of the Cancer Center in the Department of Epidemiology and Cancer Control. She is a faculty affiliate in the University of Memphis School of Public Health and University of South Carolina Arnold School of Public Health. As a social and behavioral scientist, her research focuses on cancer-related health disparities in cancer prevention and control, and specifically on working with stakeholders to effectively use what we know works to increase HPV vaccination. This involves examining, describing, and intervening on cancer-related health disparities through innovative approaches in partnership with communities, defined broadly and diversely. Her research emphasizes dissemination and implementation of.
Dr. Brandt has indicated she has nothing to disclose.
Thank you so much for inviting me to join you and talk about preventing HPV cancers with rural communities. I grew up in rural Iowa, and so rural life is really important to me, my family, and so many people that I love. And I'm reminded all the time of the strengths of what happens in rural communities. People are resilient, they're self-sufficient, there's a strong sense of community, and there are many other notable strengths that make up this fabric of rural life. Yet it's these same strengths that may make someone living in rural America less likely to seek preventive care, and that's true for HPV vaccination as well. We know from a study by Dr. Kelly Blake and colleagues in the National Cancer Institute how investing in rural cancer control is important. They've consistently emphasized the need for this rural research to address broader determinants of social health, economic influences, education, cultural differences, and others that influence the trust in and attitudes toward institutions, healthcare providers, and government. And there are also in rural communities relationships between comorbidities that increase the complexity of single focused interventions. So these are important to keep in mind as I set the stage for today's focus on HPV vaccination. So during my presentation today, I'm going to discuss the state of HPV vaccination and HPV cancers in rural settings, describe determinants of low HPV vaccination rates among rural individuals, and explain opportunities for increasing HPV vaccination through effective interventions and how we can account for rural context when doing so. So let me jump right in with HPV cancers and HPV vaccination data. So we're all more than one thing at any one time. And it's important to note that when we can consider how we're going to approach HPV vaccination with rural communities. Dr. Whitney Zond and colleagues led a review study recently to examine intersectional identity in rural communities to better understand the influences on cancer disparities. This work builds on Dr. Zond's previous work that showed very clearly that rural populations have high levels of HPV cancers compared to urban counterparts. And there are also differences within rural populations. This map shows the high levels of heterogeneity within rural America. So that fabric I mentioned earlier that makes up rural life, there are lots of different people from different places who share different identities, multiple and intersectional identities that are living in rural spaces. So our intervention approaches can't be monolith because these communities aren't just characterized by the term rural alone. There's so much more than that. So, and now specifically for HPV vaccination, geographic disparities are significant. So this map here shows the 2019 NIS teen data up-to-date coverage among 13 to 17-year-olds. And there are major differences in the South and in the Intermountain West. And across the South in particular, Mississippi has the lowest uptake at about 30.5%, and Louisiana has the highest at 59.5%. The mean across Southern states is about 5% lower than the US average. And while there have been improvements, and kudos to all of you in Louisiana who are leading the way in the South, geographic disparities persist. Rates can also differ significantly within a state, jurisdiction, or territory. So if I were to show you a map of HPV cancers in the United States, you would see these areas with the lowest HPV vaccination uptake having the highest rates of HPV cancers. So we have to identify regionally appropriate strategies to account for the uniqueness in geographic regions with low HPV vaccination uptake in the United States. And this includes in particular these rural areas. So here's another look at these NIS teen data for 2018 and 2019. And I've selected a few southern states and mid-southern states to show these differences in HPV vaccination of one or more doses and up to date. Louisiana, as I noted, and as I'm sure all of you are aware, had a really nice jump from 2000 to 2018 to 2019 and really leads the way in up-to-date coverage here in the South. Here's another look at HPV vaccination with all recommended adolescent vaccines. So that would include pertussis or whooping cough and meningitis vaccines as well, also recommended at the 11 to 12-year-old age range. So this traditional CDC figure gets shown a lot, and coverage for all of these recommended adolescent vaccines has shown improvement over time. And you'll note there's a change in the methodology in 2018 and a couple of measures that also denote the difference from the ACIP change from 3 doses to a 2-dose schedule in 2016. But overall, take-home message here is that we have seen increased uptake, maybe slow, but we have seen increased uptake. HPV vaccination coverage in rural areas, however, has been consistently lower as compared to urban areas in the United States. So from 2013 to 2018, the magnitude of the disparity in the 1 or more HPV dose coverage between mostly urban and mostly rural communities did not improve. The range and the difference has gone from about 11 percentage points to 16 percentage points, with a current difference of 12. So this means that in rural areas, the HPV vaccination coverage is about 12 percentage points less than urban counterparts. So in Louisiana, where y'all are doing great work with HPV vaccination, there can still be variability in rural regions. And on average, that's about 12 percentage points. We also know that coverage has been significantly lower in these rural areas, regardless of poverty status, sex, and race ethnicity, except among Black non-Hispanic adolescents. So the state of HPV vaccination in rural areas is that it's lower than in urban areas. And overall in the United States, we fall short of the Healthy People 2030 goal of 80% vaccinated. So while we have work to do and there have been improvements, there are still some areas left behind, including rural communities, that require our specific attention. So let's talk about what we can do in rural communities and what we know about this research that's been done. So to date, there's been a lot of research done in rural areas that's been primarily non-interventional when it comes to HPV vaccination. So we've had to take some time to look at these determinants and understand key influences on HPV vaccination in rural areas. So a take home here from this study is that people who are living in rural areas are less likely to be aware of HPV and HPV vaccine and less likely to believe that HPV can cause cervical cancer as compared to people living in urban areas. So across all of these different hints data points, we see those differences between rural and urban settings. So this becomes important because oftentimes you'll hear, well, now almost everyone has heard of HPV or HPV vaccination. And so the assumption is made that awareness and knowledge-based efforts are no longer needed. And clearly they're needed in rural communities in combination with ways to put that knowledge into action. So we have an opportunity through some awareness and knowledge building that can help drive action and uptake of HPV vaccination. So in this study by Dr. Karen Peterson and colleagues, they wanted to identify barriers and facilitators to HPV vaccination uptake in the United States. And they looked at articles that were published on rural communities and different factors. You can see here that the vast majority of factors that were identified through their systematic review processes were at the individual and interpersonal level. And specifically, many were related to demographic characteristics of vaccine recipients and the parent or caregiver. Knowledge, again, came into play, and then attitudes or motivation to vaccinate. There were very few factors at the organizational and community societal level. So here's another look at completion as compared to initiation, and we see very similar carryover from the barriers and facilitators identified. So overall, for HPV vaccination interventions and building on those determinants that we just learned about for rural communities, there's a blend of ways in which we can then act on putting that information into practice through appropriate interventions that are multi-level and multi-component. And the Community Guide for Preventive Services identifies two different types of interventions that work best and have been shown to be evidence-based. And those include healthcare system-based interventions and community-based interventions. Healthcare system interventions are really functioning on that supply side of things, and community-based interventions are designed to generate demand. And so in combination, this supply and demand equilibrium and balance allows for healthcare systems to be ready and for parents and caregivers and those seeking vaccination to be equally ready so that they meet and vaccination happens. And these have been shown primarily to happen in non-rural settings. So what do successful interventions look like in rural US settings? So with colleagues, Dr. Robin Vanderpool, Megan Pilar, and Maria Zubizarreta and Lindsay Stratman, we conducted a systematic narrative review of published interventions focused on rural US communities to increase HPV vaccinations. And so in this narrative review, we looked at articles from 2006 to 2019, and 15 articles met our inclusion criteria. And these articles were published from 2011 to 2019. The majority of these studies reflected multi-level approaches across patients and parents, healthcare providers and settings, and communities. And the intervention approaches included educational strategies, communication strategies, provider recommendation, and also access to HPV vaccination. There were varying levels of engagement and types of engagement that were reflected in these articles as well. And the two most common approaches in these articles that we reviewed were to address healthcare providers and systems, focusing on healthcare provider recommendation specifically. So what did we find across these published articles? We found that multi-level is important and also multi-component is important. That allows for myriad strategies to overcome barriers that I identified earlier and enhance facilitators that I also identified to improve HPV vaccination in rural settings. There's been so much emphasis, however, on these individual level barriers only, and less so on environmental and system level barriers. So our review did reveal mismatched evaluation approaches that didn't necessarily correspond with the multi-level nature of the intervention. So back to that complexity and heterogeneity of rural communities, they require equally complex interventions to effectively address issues like HPV vaccination, because these multi-level and multi-component approaches can attend to resources, cultural values, geographic location, economic status, among other considerations, and the importance of engagement with trusted rural stakeholders in rural communities can't be underestimated. We also know that there were gaps in measurement and reporting. And so for this type of research, we want to understand the influence on actual behavior, so on actual HPV vaccination. And we found that there were some major mismatches in terms of measurement and reporting across these interventions. So it was challenging to understand fully the impact of one strategy compared to another because of some of these mismatched evaluation approaches. We also know that there are opportunities to really do better in how we define rural, because few of these studies really provided us with important contextual information on the rural setting. So it may be possible that just using a descriptor of rural or the location would convey a rural setting, but rural populations, as I've already said several times, aren't monolith. And so we want to make sure that we understand who makes up these rural communities, so that if we want to replicate an approach that's been successful in a rural setting, that we can do so by understanding how it will or will not need to be adapted in another rural community, or how it can be strengthened in another rural community. So reporting on these important contextual factors matters. And of course, if we're going to do work in the space of understanding contextual factors, engagement with trusted rural stakeholders is once again incredibly important. So in addition to the narrative review, we've also taken a look at other strategies that improve uptake of HPV vaccination in rural settings. So this ties back to that supply and demand idea, thinking about community and clinical linkages. So we found a focus on these linkages to address both these supply and demand challenges to be really important, and also incredibly important to take an assets-oriented approach when working with rural communities. Instead of focusing on what's not there, build on what does exist and work creatively with those trusted people and organizations in rural settings. Work in rural settings also has to account for some access to care challenges, especially for a multi-dose vaccine, as is the case with HPV vaccination. So other HPV vaccination research in rural settings has focused on looking at areas outside the medical home to increase access points and reduce missed opportunities. So I've included a few of these here, and those include school-based approaches. So where do people gather in a rural area? In schools. Where are rural folks getting information or accessing healthcare services? Oftentimes in pharmacies. Dental clinics that may exist offer similar access and touch points. And mobile vaccination clinics have been another strategy that has been shown to be promising in working with rural populations to increase vaccination uptake. Another area of interest is in the policy front, and how policy change can help to improve the structure to support practice and really to help shift social norms. To remove these barriers and increase HPV vaccination in rural areas, policy measures can be really helpful to decrease those disparities that are observed. So in this work, we really conceptualized policy level change to happen across other levels, not just when we think of state level policy or federal level policy, but really what's happening in your own backyard in those systems and structures. So this table here provides a bit of an overview of those different little p and big P policy opportunities. So to improve HPV vaccination in rural US communities, there are several opportunities. And so our efforts to do this are urgently needed, given the elevated rates of HPV cancers and low rates of HPV vaccination uptake in rural communities. Strengthening the evidence base by accounting for rural context and using what's been shown to work in other settings, being thoughtfully adapted for implementation in rural areas, can guide these efforts. And so here I've summarized these many opportunities for improvements. There's more attention being played to HPV vaccination in rural settings. And we know that during the pandemic, because of the detrimental effects on preventive services overall and vaccination uptake, this urgency has even been heightened. But while we're doing research and seeking to understand the best ways, we also know that there's a need to act now. And so these opportunities really imply actionable steps that can be taken, which is really what I hope to have time to focus on here with you today. So I'm going to highlight two of these: healthcare provider setting and system interventions that can work well in rural settings, and also ways to build HPV vaccination confidence. We know there are awareness and knowledge differences in rural settings as compared to urban areas. And so we have to be intentional in how we go about sharing awareness and knowledge in a way that's going to help to build confidence. So first, healthcare providers and healthcare systems interventions. One of the greatest facilitators in uptake of HPV vaccination continues to be a strong provider recommendation in a supportive system to help drive up HPV vaccination rates. And the best approach that's been shown to be up to 10 times more effective compared to any other is a presumptive recommendation, where a healthcare provider notes a child's age, announces that the child is due for vaccines that prevent disease, and emphasizing that that will happen today. So what does this look like? Well, now that Abigail is 11, she's due for 3 vaccines to protect her against meningitis, HPV cancers, and whooping cough, and we'll give them at the end of today's visit. This is a presumptive approach or announcement approach. Doctors Noel Brewer and Melissa Gilkey have really been developing this way of announcing the need for vaccination. And this alone can help instill confidence in a parent or caregiver. So this approach really focuses on trying to move forward the conversation as a normative approach. We give vaccinations here. These vaccinations are routinely recommended. We expect that you will accept these vaccinations. And then if there's any pushback, there are opportunities to connect parents and caregivers to additional resources and also counsel. So if you are a healthcare provider or working with healthcare provider systems, please check out hpviq.org to access these and additional resources that really help focus on this strong provider recommendation. We also know that changing clinical practice isn't easy. And so that supportive environment from check-in to check-out in a clinical system really matters. And so it takes intentionality and it takes time and effort to really move to a very supportive pro-vaccine environment. And there are some barriers and pushback in clinical settings. So these are have been identified by Dr. Brian Mittman and the Improving Adult Immunization Performance, just really some general insights about how it's possible to improve clinical practice for your consideration. But again, it is that check-in to check-out mindset that we want everybody to be on board with the fact that we support vaccinations, including HPV vaccination for cancer prevention. The American Cancer Society has an excellent guide called Steps for Increasing HPV Vaccination in Practice. If you haven't seen it or used it, highly encourage you to reach out to your local ACS contact or get in touch and access this resource through the American Cancer Society. The steps really focus on nesting an intervention approach around assembling a team with a vaccination champion, quality improvement approaches, identifying external supports, and then also making a plan and putting that plan in practice. And it really embodies this from check-in to check-out, understanding how the whole office can really influence vaccination uptake. And then lastly, the strong provider recommendation to really bring it home. And the HEDIS measure currently is to get patients vaccinated by their 13th birthday. And the American Cancer Society and the American Academy of Pediatrics both recommend starting these conversations at age 9 in order to achieve that. The ACIP recommendation for routine vaccination is at age 11 to 12 and as early as age 9. But this guide and other resources will really focus on starting at age 9, which is probably one of the single greatest shifts we've seen in the last couple of years that hopefully can drive earlier uptake and ensure completion by the 13th birthday when we know there are the greatest benefits. So building confidence in HPV vaccinations is really challenging. So before COVID-19 vaccines were introduced, HPV vaccination had the dubious distinction of going with seasonal influenza as the vaccines for which there were the highest levels of hesitancy that influenced uptake or lack thereof. So vaccine acceptance occurs on this continuum of a level of vaccine confidence and acceptance. So refusing all vaccines is on one end of this figure, and accepting all vaccines on time or as recommended is on the other. And somewhere in the middle, and even more trending towards that accepting all on time, is where a lot of people fall. So this emergence of hesitancy, reluctance, or refusal to vaccinate despite availability and access to vaccines really is what we mean when we're talking about vaccination hesitancy. So in simplest terms, vaccination hesitancy really threatens to reverse any progress that's been made over the years in tackling vaccine preventable diseases. The World Health Organization in 2019 named vaccine hesitancy as one of the world's greatest global health threats currently facing us. So this delay in acceptance or refusal is really influenced across time and place and vaccine type as well. And complacency, convenience, and competence are the three factors that often get mentioned in vaccine hesitancy discussions. And in rural settings in particular, trusted messengers are incredibly important. Who delivers what message is important, and healthcare providers historically are the most trustworthy source of information for parents, even for those who believe vaccines are unsafe and for those who request exemptions for some vaccines. It is the healthcare provider who's sought for advice and guidance. So it's important to emphasize the development process. No corners were cut. The vaccine development process is rigorous. Clearly communicate risks and benefits in language to be understood by the audience, and confront misconceptions and myths. And these are especially prevalent right now with COVID-19 vaccination, and have the potential to trickle over into other vaccines that have been subject to hesitancy concerns, including seasonal influenza vaccine and HPV vaccine. And the World Health Organization has actually laid out what these influences are. I'm not going to go into detail, but suffice to say that there are contextual factors, individual and group influences, and then vaccination specific issues. And these have really emerged in rural US communities as being highly prevalent and requiring special and unique attention to ensure that we're going to be able to provide the information needed to make decisions that are informed. And hopefully in this case, to understand how HPV vaccination serves as an important cancer prevention tool. A recent study showed that about a fourth of all US parents are hesitant about HPV vaccination. And you can see here that a healthcare provider's recommendation has a lot of influence on whether or not a parent is going to be willing to accept HPV vaccination. And there are myriad other factors that are complex and work together to create almost this intersectional web of hesitancy. And as you may address one concern, others emerge, or they're connected to some. So we have to think about how are we going to give these messages in a clear and articulate way. So healthcare providers are important messengers, starting early and building trust, choosing messengers who are going to be knowledgeable and be able to answer questions. This is particularly important in rural communities. So who has the say? Who are the gatekeepers? Who can really provide accurate information using language that is familiar and will be trusted? The topics themselves have to be tailored to the specific concerns of the audience. And vaccination has to be considered the default approach, that it's normative to accept vaccination. And being balanced in talking about, yeah, it's a vaccine. Yes, there may be pain and soreness at the injection site. Yes, I understand that you have those fears or concerns. However, it's also cancer prevention. And when you think about, we have this vaccine that prevents 6 types of cancer, it's important to make sure that there's a normalization approach as well. And that's how messages can be framed. They can be framed using stories and really being careful when addressing misinformation, acknowledging someone's belief, but saying that's perhaps just not the case. Here's what I know. Here's been my experience. Perhaps this is why cancer survivors in rural areas can be really important if they feel comfortable sharing their own journey and story, saying, I don't want what happened to me to happen to your child in the future. HPV vaccination is going to help prevent your child from getting these HPV cancers in the future. There are also some messages that are available and existing for counseling hesitant parents. And these are from, again, the hpviq.org website. You can see that is an emphasis on it's normal, kids respond very well, and it's cancer prevention. So just to sum up recommended messages, and of course, these will need to be tailored to the rural context, but normalizing HPV vaccination, that it works really well, and that the vaccine supports families by protecting the ability to have children and helping people stay healthy to see their grandchildren. And these actually came from Dr. Rebecca Perkins and others as part of a national HPV vaccination roundtable meeting. And I couldn't sum it up better to say that HPV vaccination is cancer prevention. And that's true in rural communities, just as it's true in urban communities. So if we can attend to the uniqueness and strengths in rural settings by emphasizing these messages and approaches, ensuring there are strong healthcare provider recommendations, and also working to build confidence, we have the opportunity to help increase uptake in rural areas. So let me take a moment just as I wrap up to share a little bit about our St. Jude program, because we really do look forward to connecting with you in Louisiana and finding out how our program can support your efforts. And we also want to take what's working well for you and make sure other places in the South are putting that in practice as well. So at St. Jude, there's a lot of what if questions that get asked as part of a blue sky process. This blue sky idea is that how can St. Jude have a big impact and really accelerate progress in different areas? And so the question was asked, what if we could accelerate efforts to provide adult cancers by vaccinating children? So our program launched officially in March 2021, actually on March 4th, which is International HPV Awareness Day. And we are really focused on finding out how we can galvanize existing successful efforts that may be limited by reach and resources. How can our program take what's working and get it into more places for greater benefit? And how can our program contribute in emerging areas? So these areas where the pandemic right now is a prominent one, where we're trying to step up and invest in ways to lessen the negative effects of the pandemic on vaccination. So I hope you'll keep that in mind. We have a great team and we are building. We are actually currently hiring 2 new program coordinators. We'll be bringing on postdoctoral fellows. So if you're in that situation, stay tuned for more students and then additional full-time staff in this fiscal year. And broadly, our program, in terms of galvanizing existing successful efforts and contributing to emerging ones, we're doing that in the community space, the clinical space, the public policy and advocacy space, and always with partners. Partnerships are really foundational. We know there's great work happening, so we're not coming in to push others out, but to join forces to strengthen these efforts and go farther together. One example of something that may be of interest is we conducted an HPV vaccination policy analysis in 4 selected states to really understand the influences of policy on HPV vaccination. So you can access this report on our website and also a recorded virtual seminar that may be something you might want to take a look at too. But our program is getting off the ground. We're starting to do a lot of great work and welcome opportunities to work with you in Louisiana. So HPV vaccination prevents cancer. There have been more than 270 million doses distributed worldwide. We now know that HPV vaccination has reduced precancers by 86% among those who are vaccinated. And we know HPV vaccination is preventing cervical cancer based on large studies in other countries. These are important developments, and we want to make sure that every child today is protected from HPV cancers in the future. I hope you'll follow up with me if you have any questions or would like more information. And at the end of my slides, I've also included some resources for clinical interventions, community building confidence interventions, and also resources that are available right now to help get back on track with vaccination as a result of the pandemic. Thank you. And I look forward to hearing your questions. Although we're not doing this live, please do reach out to me by email. I would look forward to having a conversation with you.
Thank you for watching today's presentation. We hope that it was educational and gives you ideas for implementation. After viewing all the presentations in the series, please complete an evaluation feedback form by scanning the QR code you see on your screen or going to www.surveymonkey.com/r/2021 LA-HPV Summit. Your feedback is valuable as we continue to plan future events. In addition, you will be asked for your mailing address. As a participant in the series, you will receive a copy of all presentations on a flash drive, in addition to several other resources. We hope this has been helpful to you. Should you have additional questions or want additional information, please reach out to the Louisiana AAP either by calling 225-379-7923 or emailing admin@laap.org. Thank you again.